Us. Today we shall discuss on rheumatic heart diseases in children. It is said in rheumatic fever, it licks the joints and bites the heart. This means there is no residual effect on the joints, though that is one of the commonest presentation of rheumatic fever, but it bites the heart. That means it remains sequelae. It causes valvular destruction of the heart. Rheumatic heart disease is a sequelae of rheumatic fever, and it is the most serious manifestation of the acute rheumatic fever. In 30 to 45% cases of acute rheumatic fever, a child develops rheumatic heart disease. So in this, there is damage to cardiac valves. Chronic and progressively it causes the damage and leads to congestive heart failure and even death if untreated timely. So now come to the valves which are affected in rheumatic heart diseases due to rheumatic fever. So more than 90% cases mitral valve involvement is there. In that also mitral incompetence is more common than mitral stenosis. Next is the aortic valve, and then tricuspid valve and pulmonary valve is very rarely affected. So in the mitral valve, predominant is mitral regurgitation. So today we'll discuss on mitral regurgitation, and less commonly child develops mitral stenosis. In the aortic valve, aortic regurgitation is commonly seen, whereas rheumatic aortic stenosis has never been described below the age of 15. So you can say it does not occur. And tricuspid valve involvement is infrequent. So the commonest manifestation is rheumatic regurgitation, mitral regurgitation due to rheumatic fever. So mitral regurgitation, it is the commonest valvular rheumatic heart disease. Here this mitral valve undergoes fibrosis, which is resulting in shortening of the mitral valve, leading to mitral incompetence. That means the valve cannot close properly. So mitral valve fails to close completely during the ventricular systole. So just follow the diagram and see. Right side is the involved heart, left side is the normal heart. So in the mitral regurgitation you can see this left ventricle is emptying in two places. There is regurgitation of the blood from left ventricle to left atrium, which means this left atrium becomes engorged because it is also getting blood from the pulmonary veins, and then the remaining blood is going to the aorta, which is the normal flow. So with that you can see there is a backward leak in the left atrium from left ventricle, and this forward flow to the aortic valve to the systemic circulation will be less. The blood is shunting towards the left atrium, so the aortic blood flow will be less. So the changes, if you see, during the ventricular systole there is regurgitation or backflow of the blood from left ventricle to left atrium. So during this time, when the blood is flowing through the valves, it creates a pansystolic murmur. But during diastole, it is seen that blood is freely crossing across the mitral valve to the left ventricle. So left atrial pressure during the systole is high and drops during the diastole. So the mean atrial pressure remains normal or only slightly increased. So this means there is no pulmonary congestion and no dyspnea or heart failure occurring in mitral regurgitation unless it is very severe. When the mitral regurgitation is very severe or acute on onset, then there is a acute hemodynamic overload in the left atrium. So left atrium does not get time to dilate. The size is remaining normal. So in a small size, increased amount of blood will create increased pressure in the left atrium, which means this is transmitted to the pulmonary venous pressure. So in this case, pulmonary congestion and heart failure can occur. Whereas if the mitral regurgitation is a long-standing one, not a acute but a long-standing slowly progressing one, then the left atrium adapts to the larger volume of the blood by dilating. It gets time to dilate in the size, so which increases the compliance, and there is no increase in the pressure leading to heart failure. So with increased amount of blood in the left atrium and left ventricle, both may enlarge in size. Now we said to the aortic flow there is a reduced amount of blood because part of the blood is ejected back to the left atrium. So that is why during exertion the forward output will be insufficient, and these patients will feel or complain of fatigue, which is the commonest symptom of mitral regurgitation. So in the flow chart showing the same thing in brief. So backward flow leading to increased pressure volume in acute condition leading to pulmonary venous congestion and pulmonary edema, heart failure. Whereas when there is a slowly progressive course, then during the systole there is increased pressure in the left atrium, but during diastole the blood is flowing back normally, so mean atrial pressure is remaining normal. So there is no increase in pressure, no pulmonary congestion, and then no heart failure. So blood is ejected to the aorta, which is reduced in amount, leading to fatigue, which is the commonest complaint. Now come to other clinical features. So child may remain asymptomatic during childhood. Fatigue is the commonest presentation. There is wide pulse pressure. There is no left ventricular failure unless the MR is very severe or acute, and then you may get palpitations due to the increased stroke volume and also due to the atrial fibrillation. Coming to the physical examination in the precordium, apex is displaced downward and outward and is having hyperdynamic apical impulse if the MR is severe. If it is not severe, apex remains normal. And then S1 first hour sound is normal, soft, and then masked by the pansystolic murmur. S2 is split widely in case of moderate to severe MR. And the hallmark of the MR is that regurgitant pansystolic murmur, the grade ranging from 2 to 4/6, heard at the apex with radiation to the left axilla, back, and left sternal border. Now come to investigations. You have to do ECG followed by X-ray. So normal to mild MR will have left ventricular hypertrophy without left atrial hypertrophy, and in adults you may get atrial fibrillation. In the X-ray chest there is cardiomegaly, pulmonary venous congestion in severe cases. If you do echocardiography, there is dilated left atrium and left ventricle, regurgitation flow into the left atrium. Treatment: prophylactic penicillin can be given. Heart failure, digoxin, diuretics, vasodilators are used to manage the heart failure, and ultimately valve repair if the MR is very severe. So valve repair, or you can do the prosthetic valve implantment also. The natural history of the MR: they might develop infective endocarditis, which is rare, left ventricular failure and pulmonary hypertension in adult life, and in case of chronic MR the left atrium dilate in size, and then the compliance remains good, so child is not having heart failure, whereas in acute condition they will have heart failure. So this is all for today. Thank you. We'll meet in the next class again.